Well, good afternoon and welcome. Good day to all of you. This is the webinar for the Perinatal Mental Health Education and Screening Project. Just want to make sure you're in the right Zoom room. If you're looking for another topic, we'll let you go. But we're thrilled to have so many people joining us today to discuss this year-long project. Welcome, all of you, and thank you for taking time from your very busy lives to be with us here today. And next slide, please. Just a few brief housekeeping issues. This is a webinar, and so if you would like to put a question in for discussion at the end of the session, please go ahead and put it in the Q&A feature of the chat. We are also recording this webinar, and the slides and the webinar will be uploaded to Maternal Mental Health Leadership Alliance's webpage, and we will share that link after the presentation. Next slide, please. So, hello again, my name is Adrienne Griffin. I am the Executive Director of the Maternal Mental Health Leadership Alliance, where our mission is to advocate for national policies around mental health care during pregnancy and the year following pregnancy. And on behalf of MMHLA, welcome all of you, as well as our partners from the March of Dimes. Next slide, please.
Thank you so much. I'm Tiffany Aquino. I'm the Vice President of Innovation and Product Development at the March of Dimes, and so glad to have you all join us today for this very important topic. Looking forward to the discussion ahead and the report that's forthcoming with that. Thank you, Adrienne.
Thanks, Tiffany. And MMHLA and the March of Dimes have been working on this project for, well, we started in September of 2021, so a little bit over a year. We are really, really thrilled to share the information that we've uncovered over the course of this project. And we'll be presenting a report as well, and we'll be sharing all of that with you as soon as we have tied up all the loose knots on the report. So next slide, please. I also want to give a shout out not only to our terrific partner of the March of Dimes, but also to the organizations, the funders who have made this possible, and that's the California Healthcare Foundation, Johnson & Johnson, Sage Therapeutics, and the Zoma Foundation. Next slide, please. And here's just a quick overview of the project's goal and our goals for today's webinar. So the goal of the the Education and Screening Project was first to synthesize existing screening guidelines from a variety of organizations about perinatal mental health, when to screen, and then to really focus on when to educate and screen pregnant and postpartum people about mental health issues throughout the 2-year perinatal time. So that really is what frames this whole project. And our goals for today are to share the framework with all of you, highlight next steps, get your feedback, and have some discussion. All right, so I'm going to preface all of this and say there's going to be a lot of information that is coming at you today. And again, the presentation and the webinar will be shared on our website. You need to go back and listen to things. And of course, we're always open for questions and comments afterwards. And we'll be posting information on how to follow up with us at the end of the webinar. All right, next slide, please. So we're going to start with, we'd love to know about you. What brings you here today? So we're going to launch a quick poll. And if you could just check for us, what made you interested in joining our discussion today? All right, there we go. So that poll should be open. And it is multiple choice, so you can select as many of these answers as apply to you. And as we're waiting for this poll to close, just a reminder to those of you who have entered a little bit late that the presentation and the recording will be available on Maternal Mental Health Leadership Alliance's website after this, and we'll send a link when the webinar is over. So I think we are, how's that poll coming along? Okay, great. So it looks like we have about 130 people who responded. We've got lots of people in the fields of mental health and maternal child health, a good number who have experienced, lived experience with a perinatal mental health disorder or know somebody who did. And I love it that so many people want to make a difference in the world. Thank you. All right, so let's proceed. All right, so I'm just going to spend a few minutes giving an overview of the project just to orient everybody to the work that we've been doing. So here is our project approach. So across the whole range of the project, we were very committed to convening individuals from a diverse range of professions, experiences, and communities. We wanted to cast as wide a net as possible. In doing so, we also recognized and acknowledged the barriers inherent in the complex medical and mental health systems in our country. We also were very committed to use a data-driven and evidence-informed approach to this work. And we focused on an ideal framework that would ensure that the majority of pregnant and postpartum people educated about and screened for perinatal mental health disorders. Next slide, please. And we approached this project really focused on when providers should educate and screen their perinatal patients. There were so many questions about when to screen, what screening tool to use, how do I get reimbursed, all of those many, many questions. We really honed it down into this one specific thing, focused on when providers should educate and screen their perinatal patients. In doing so, we want to recognize, of course, that racism, bias, and inequities in the healthcare system actually result in deep-rooted disparities. And so we were very, very intentional to take steps to gather information regarding racial and health disparities, and again, being very thoughtful about who we included in this project. And we're committed that additional work on this project will continue to center equity in maternal and mental health care. Next slide, please. Okay, so here's just a quick overview of the Perinatal Mental Health Education and Screening Project. We use the short term screening project just because that's a long phrase that we need to keep repeating. So we started the screening project way back in September of 2021. We gathered a core team of 5 individuals who are committed to this project throughout the whole course. We gathered data and created a work plan, then convened a working group last January, just about this time, of 35 people who created the draft frameworks that we'll share with you today. Then we hosted a series of focus groups, or what we called roundtable discussions, to get feedback on the draft framework. Then we reconvened the working group in November to finalize the framework and discuss next steps. And in the meantime, the core team has been spending time writing a report, securing additional fundings, wrapping up phase 1, which is where we are now, and planning for phase 2 of this project. Next slide, please. And here's just a quick look at the participants. So our core team, as I said earlier, was the small team that has been kind of driving this throughout. The working group included organizations from maternal child health, mental health, affiliated providers, and many folks with lived experience. And then our roundtable discussions, we really had a great group come together over the course of 11 different meetings. We had individuals with lived experience. We worked with partner organizations, and we had some roundtable discussions focused on specific provider groups. Next slide, please. And the next couple of slides are just going to give a little bit more information about our different teams. So here's a look at the core team. Again, it was a partnership between the March of Dimes and Maternal Mental Health Leadership Alliance, and you see who was on our team as well as who provided staff support. Next slide, please. And this slide just lists all of the different organizations that were included in the working group. That was that large group of about 35 people who drafted the framework that we'll be sharing with you today. Next slide. And then our roundtable discussions, as I said, we had 11 roundtable discussions or small focus groups with about 175 people. We partnered with the March of Dimes for some specific groups that are MBAN network. We also partnered with Postpartum Support International and held a focus group at their conference, also with the Mind the Gap, so existing partner organizations. And then the first several groups we had, we really focused on individuals with lived experience. We knew it was so important to center this whole project on their experience. And we had particular focus groups for those who are most impacted by these illnesses. So Black, Latinx, and AIAN individuals. And then we shifted gears and we started focusing on provider groups. So we did a group for obstetric and then pediatric providers, for mental health providers, and community-based providers. Next slide, please. All right, so that's an overview of the project. Now I'm going to quickly do a quick overview of perinatal mental health disorder. Next slide, please. I'm guessing that for most of you, this is a little bit of a refresher, but again, I just want to say that there's kind of going to be a lot of data coming out at you. So just, again, these slides will be available afterwards if you want to go through them again. So when we talk about perinatal mental health disorders, what we're talking about is mental health issues that impact individuals during pregnancy through 1 year following pregnancy. So it's really this 2-year perinatal time frame. And we're talking about a whole range of mental health issues. So both depression and bipolar illness, as well as anxiety disorders, including OCD, PTSD, substance use disorder, and psychosis. So what we used to say postpartum depression, meaning postpartum after the baby was born, and depression, we know so much more about. We know that these illnesses can begin during pregnancy, and that it includes much more than just depression. Next slide, please. So just a few other facts and figures. We know that perinatal mental health disorders are the #1 complication of pregnancy and childbirth, affecting at least 1 in 5 pregnant or postpartum people, and as many as 1 in 3 in some high-risk communities. We know that untreated, these illnesses can have a long-term negative impact, not only on the parent, on the baby, but also family and society. And so for all of these reasons, this is why we really are paying attention to these issues. Next slide, please. So just a word or two about timing. As I mentioned, that many of these illnesses start during pregnancy. And so there was a study done in 2013 that shows of those individuals who experience perinatal mental health disorders in the postpartum period, about 1/3 enter pregnancy with underlying symptoms. Another third develop symptoms during pregnancy, and then 40% develop symptoms in the postpartum period. So this underscores the need to start talking about mental health issues immediately during pregnancy and not waiting till the postpartum timeframe. Another study done in 2020 shows that these illnesses can last longer than we previously thought. So 25% of those who experience a perinatal mental health disorder actually had depressive symptoms if untreated out to 3 years postpartum. And so those are those individuals who are coming back into their next pregnancy with those underlying symptoms of anxiety and depression. Next slide, please. And here's some information about the rates of these illnesses in the postpartum timeframe. So the peak onset of postpartum depression is 3 to 6 months postpartum. We often hear women say that their mood changes around 6 months postpartum. This often coincides with the cessation of breastfeeding or the return of menses. So these huge hormonal shifts can really impact people's mood. And then the peak incidence of suicide is 6 to 9 months postpartum. And so we can see again why it's so important to be screening for mental health conditions the entire perinatal period, from conception all the way through baby's first year, or for the first year following pregnancy. Next slide, please. And I do just want to note that we're using the term perinatal mental health disorders. There are many terms that are used to describe these illnesses. Perinatal mental health issues, perinatal mood and anxiety disorders. Sometimes we still hear postpartum depression, antenatal depression. We're just trying to use a term that is all encompassing. Okay, so we noted when we started this work. So the first thing that we did was gather all of the screening recommendations put forth from various national organizations. And each, unfortunately, none of these sort of align. So the result is that each state, each healthcare system, in fact, every hospital, practice, or provider can actually decide when and whether to screen. And the result is widespread and unacceptable disparities in addressing these important illnesses. Next slide, please. So again, our focus was really focused on when to screen. We wanted to know what would it look like to take the journey of perinatal people, pregnant and postpartum people, and their partners to identify existing screening opportunities, times and places where they were already interacting primarily with their medical provider, and then leverage this information to maximize the likelihood that pregnant and postpartum people and their partners are not only educated about, but screened for these illnesses and connected with resources for recovery. Next slide, please. So we figured once we came up with this screening timeline, we'd be able to address some of these other issues that we kept hearing about. For example, we hear that screening tools may need to be adjusted or updated. We hear over and over again from providers that they face barriers in screening, such as lack of reimbursement and lack of training, lack of knowledge about where to send impacted people, as well as the need to create performance measures so that on a system-wide basis, we can see, is screening working? Are we able to help connect people with resources and hopefully in some cases actually prevent these illnesses? Next slide, please. Okay, so at this point, I am going to turn over the microphone to Amina Balogun, who is a staff member at Maternal Mental Health Leadership Alliance, and she is the Education and Screening Project Manager and has been working on this issue for the last year and a half. So she gets the best part of this whole presentation. She is going to talk about the actual framework. So thank you, Amina. Go ahead and take it from here.
Awesome. Thank you so much for the introduction, Adrienne. As Adrienne said, my name is Amina Balogun, and I am a program manager with MMHLA. And this project has been my baby and my best friend for the past year and a half. So I'm very, very excited to share our work with you all and to hear more about what you all think about it. So let's go ahead and jump right in. Excuse me. There we go. Okay, so first, before we get to the framework, there are a few more pieces of context that we like to lay out at the beginning of the presentation, just to kind of circumvent some of the common questions that people often have, and also to kind of clarify our approach to this whole project. So number one, we believe that screening should be viewed in the larger context of mental health across the lifespan. So we know that your mental health doesn't start or end with a pregnancy, but because we are focused on perinatal mental health in particular, we really do always come back to this 2-year time frame from conception up until the first year postpartum. And in an ideal world, we'll have more linkages and connections between mental health care at different phases of life. But as I said, for right now, for this project, we are focused on that 2-year time frame. Next point is that we believe screening must include education and conversation. So when we say screening, we do mean the use of a validated tool to assess for signs and symptoms of a perinatal mental health disorder. But we also mean education and conversation, because we know that just handing someone a paper assessment and asking them to check off some boxes is not enough to really have an impact on their lives. So we intend that physicians, practitioners, community health providers, whoever's interacting with a person who's pregnant or parenting, that they should be having robust conversation about perinatal mental health and educating their clients about what to look out for. Next is that both clinical and community-based providers are well positioned to screen. So you all will see as we move through the framework that we really heavily leverage the clinical pathway, because that was the easiest way for us to kind of create benchmarks for when screening should occur. But that's not to say that other providers like doulas, lactation consultants, home visitors, all these other wonderful, great practitioners that are working with pregnant and parenting people, that's not to say that they are not capable of screening. And in fact, many of them already do. So we just like to reinforce that once again, that both clinical and community-based providers are in a great position to screen. And kind of related to that, we like to emphasize that providers and practitioners, they should all think that I might be the only one asking my patient or my client about mental health. We'd like to believe that everyone's talking about this, but reality shows us that that's not the case. So we kind of like to encourage everyone to take on that responsibility and say, I at least have to check in with my client or my patient and ask how they're doing mentally. Next, we believe that screening should occur at existing touch points and be paired with screening for physical conditions. So this is one of the big things for this project too. We really believe that mental health is just as important as physical health. And so on that plane, we like to pair them One, because we believe they're equal, and two, because it kind of makes it easier. If you're having a physical health check-in, it's also a great opportunity for a check-in around mental health as well. And next, this is kind of a recent addition. We like to clarify that providers must screen to intervene. So once again, just giving someone a paper tool is not going to cut it. We would like to see a world where that screening is followed up with intervention or referral to resources if a given provider is not capable to provide treatment themselves. And lastly, this is a one-size-fits-most approach. So by this, we mean we really approached this project intending to design a framework that would work for the largest number of people possible. That said, we do understand that there are special populations. So for example, parents who have had a child in a NICU, people with pre-existing mental health conditions, a wide array of other special interest populations that might need a little bit different of a care pathway. And so this framework doesn't dig into all of those details, but it does leave a lot of space for providers to use their discretion to work with their patients to kind of tailor this framework to their individual patient. Okay, so there's a big chunk of the context, but then there's just one more slide of context before we get to the good part. And that's, we just like to show the kind of clinical care pathway that your typical individual will be going through when they are pregnant. So starting with our regularly scheduled obstetric visits, you can see here that they ideally start in the first trimester, and then they become more and more frequent as you get to the sharp end of the pregnancy. And then moving into that first year postpartum, you can see we also have regularly scheduled pediatric well baby visits that start out more frequent and then become less frequent over the year, but they're still occurring at pretty regular intervals. And so we just like to show this to show all of the different touch points that there are between an individual and their care provider. And all of these different touch points are opportunities for screening to occur. So this is what we kind of started with when we met with our working group. We said, hey, look at all these appointments. Where do you think we should fit in our suggestions for when screening should happen? And lastly, of course, our community-based providers, we couldn't exactly, plot onto a timeline their interactions the same way that we could our regular obstetric interactions. But we know that community-based providers, our doulas, once again, our lactation consultants, they are, interacting with their patients and their clients. And so it's incredibly important that we bring them into the conversation as well and recognize that each of their interactions are also opportunities for screening. Okay, so that brings us to the good part, the framework that we created with our working group and shopped around to our roundtable discussions. If you don't remember any of the other parts of this presentation, you can just remember this one slide and you'll be good to go. So once again, we're starting with the 2-year time frame from the beginning of pregnancy all the way up until that first year postpartum, because this is the perinatal period where we know we can have the most impact. All right, just click through here a little bit. So our first suggestion is that screening occur at the initiation of prenatal care whenever it occurs. So ideally, we're going to be having prenatal care starting very early in a pregnancy, but we know that's not always the case. So we included this intentional wording to say, no matter when your first interaction is, there should be a screening at that point. And that's really just to kind of set up a baseline for an individual in their pregnancy, their mental health. Moving beyond that, we had then suggested that screening occur once per trimester during pregnancy. And this is good just to kind of have a routine check-in. It's something that you can expect from your obstetric care provider, that they're going to be checking in around your mental health. I think it's really important to kind of normalize those conversations as soon as possible, just so that, moving into the postpartum period, a patient is already aware that this is something I should be thinking about in my postpartum experience. Next suggestion is that screening occur prior to discharge from a hospital or birthing center. And this was one that we kind of went back and forth on with the working group and with our roundtable participants, but we ultimately decided to keep this recommendation in for one reason, and that is because although we would hope that everyone is receiving adequate prenatal care, we know that that's not the case for everyone. And for some individuals, the only time that they might be having a really significant healthcare interaction is when they come in to deliver their child. And so we think it's really important that screening occur at this point, or at the very least, if a formal screening is not taking place, there needs to be at least some sort of education or conversation around mental health so that the person that's just had a child and their family as well can kind of learn a little bit about perinatal mental health disorders and the signs and symptoms that they should be looking out for as they, leave the hospital and return to their home lives. And then moving into the perinatal time, or moving into the postpartum time frame, our next suggestion is that screening occur within 3 weeks postpartum. And this suggestion is in line with the American College of Obstetricians and Gynecologists' latest recommendations that obstetric follow-up occur within 3 weeks postpartum. So we figured, let's leverage that recommendation and have a similar one for our time frame. So you'll see the light blue square. So that's our first obstetric check-in. And then there's also another one at month 3, also in line with ACOG's latest recommendations. So when you're having your, ultimate postpartum follow-up at that 3-month mark, another great opportunity for screening to occur. And lastly, we suggest in this framework that screening occur throughout the first year postpartum at all regularly scheduled obstetric and pediatric check-ins. So I already referenced the obstetric check-ins, but in regard to the pediatric ones, we believe that each one of these interactions is another great opportunity for screening to occur. The American Academy of Pediatricians already has recommendations for screening to occur at some of the well baby visits. And we just kind of built upon that and said, why not use each one of those interactions as another opportunity for screening? And then, of course, here at the bottom of the screen, we have our suggestions for community-based providers. So once again, we couldn't put our doula and lactation consultant interactions on such a clear timeline as we did above with the obstetric providers, but we know that those interactions are happening. And so we suggest that community-based providers screen their patients or clients at least once during the care relationship and or per their agency guidelines. And a little bit more insight into this suggestion, we decided to go with at least once, in acknowledgement of the fact that there's a wide range of community-based providers that they might be seeing a client for 3 months, or they might be seeing them for a year, or they might be only having one interaction with them in the hospital or something like that. So because there's so much diversity within this community, we decided to just go with our recommendation of saying at least once, and then, community-based providers have discretion to screen more than that if they are able, and we definitely would encourage that. And so that is our framework all together on one slide. I think I always forget the exact number, but if you count, it suggests at least 13 screening interactions throughout pregnancy in that first year postpartum. And we really just think that's important to make sure that these conversations are happening at regular intervals, and so that no one is falling, in between the cracks. There's always going to be a check-in from either your OB or your pediatrician asking, hey, how are you doing? Let's check in and make sure that you're not experiencing any symptoms. Yes, and so just really quickly to walk through some of our rationale once again, we are recommending or suggesting that screening occur at the initiation of prenatal care. This is really important to obtain a baseline for an individual and their mental health. And also because we know that a lot of people are entering pregnancy with pre-existing symptoms that need to be taken into account. Moving on, we then suggest that screening occur during each trimester of pregnancy. And this is to kind of normalize the conversation and make sure that there's routine check-ins. Screening would happen prior to discharge from a hospital or birthing center. This is just to make sure, once again, that the conversations are happening. And for our individuals who may not have had access to routine prenatal care, this is a really important check-in. And then moving into the postpartum period, we have our suggestion that screening occur within 3 weeks postpartum. This is important because we know that the baby blues, which are kind of more normal fluctuations in mood that happen after a pregnancy, those symptoms typically resolve by 2 to 3 weeks. So if they're sticking around at the 3-week, 4-week mark, we can say, okay, this might be cause for concern. Let's do something more about it. And then once again, screening throughout the first year postpartum at all of those well baby visits, we just think it's incredibly important because the peak onset of perinatal mental health disorders is actually 3 to 6 months postpartum. So we know that there's something about that postpartum experience where symptoms can kind of pop up whenever they want. And so it's important to have routine check-ins to make sure that everyone is being screened and that no one is going without the services that they need. So I am going to go ahead and pause there, or actually pass it back to Adrienne. And as she said before, if you have questions about this framework, just kind of hold on to them or drop them in the Q&A, and we will circle back to them at the end. So back to you, Adrienne.
Great. Thank you so much, Amina. I know that was a lot of information to digest, and I know that we're getting some questions in the chat, and we will address those in about the next 5 or 10 minutes. I just want to walk through the barriers to screening that we heard over and over again during the course of this project and what we're going to be doing to address those barriers. So next slide, please. Okay, so we know that there are barriers to screening both from the provider and the patient perspective. And again, we heard this numerous times over the course of the last 1.5 years or so. In fact, people are so everybody just recognizes that this is not an easy thing to make happen. So here's what we've heard again and again from providers. They often cite lack of training, right? That they don't receive training about mental health conditions, maternal mental health conditions, or perinatal mental health conditions in medical school or in their residency programs. And only if there is somebody who's passionate about these issues within their training do they actually seek out this information. We also know that providers, of course, are not always reimbursed for either screening or discussing, counseling, or necessarily treating these illnesses. And finally, providers also tell us that they're very reluctant to screen or engage their patients on these topics if they don't have resources for those who are impacted. And I get it. I totally get it. If I wasn't trained in this and I didn't have the time and I wasn't reimbursed and didn't know what to do with people, I would not want to screen either. And so we heard providers tell us over and over again, all of these things. I don't know what to say or do. If I ask about it, will only make it worse. If I ask, then it's my problem. In some cases, the parent is not my patient. So we hear the pediatricians or those in the NICU talk about that. And so we understand and recognize that there are significant barriers from the provider perspective. Next slide. Similarly, we heard from parents over and over again that there are issues of stigma, cultural issues. Everybody's fear is if they acknowledge that they have mental health challenges, that they are fear of being considered a bad parent, and worst of all, that their child would be taken away from them. And I totally understand that. And so we hear parents say things like, I didn't know anything was wrong. I thought this is what it was just felt like to have a new baby. If they did realize something was wrong, they didn't know where to go or what to say. They were afraid or ashamed. And we've heard over and again as well that the screening tools don't necessarily ask the right questions. And so again, from the parent perspective, we understand that there are significant barriers to screening. So next slide, please. So over the course of the last several months, we really have doubled down and focused on identified 5 areas of action that are required to move further to address these barriers to screening. And it starts with with provider education and reimbursement, of course, making sure that there are adequate resources, ensuring that screening tools are appropriate, up to date, culturally relevant, and then wrapping around all of this are issues of trust and equity. And so next slide, please. We took these 5 areas of barriers, and we're trying to turn them into action items right now. And so the first, of course, is the idea of provider education and training, right? So once again, we hear from frontline providers, obstetric providers, pediatric providers, family care physicians, even psychiatrists, that they are not trained in addressing perinatal mental health. And they do not know how to screen, what to say, what screening tool to use, right? This is just something that they hadn't been educated about. And so we know that training is needed for both clinical and community-based providers so that these individuals are more equipped to better have these conversations with their patients. Makes total sense, right? Okay, next slide, please. We also heard from providers that they are not always reimbursed. for education and screening? And this is one of the questions that came through either in the chat or the Q&A. So the ideal scenario is that providers are both easily and fully reimbursed for educating and screening their patients, discussing results, and providing resources. But we know there's several implementation barriers. We know that providers are awfully busy. We're asking them to do more in their already busy schedule. There's questions about how to implement screening and work it into workflow. And of course, reimbursement. Right now, Medicaid reimburses pediatricians for screening, but of course they have to file specifically to get reimbursed. And Medicaid currently does not specifically reimburse obstetricians for screening. It's not part of the bundled care package. And so there's significant barriers around reimbursement. And then we also hear from frontline providers, mental health providers, counselors, therapists, social workers, that, you know, if they seek reimbursement from Medicaid, but they are not reimbursed at high enough rates, and that it's very, very difficult and time consuming and very high administrative burden to become paneled with insurance programs. And so we have frontline providers who can actually provide counseling who are, difficult to access. So the reimbursement needs to better support education and screening, and we need to work on a whole variety of things, everything from updating the DSM, ICD-10 code, so a whole lot of work around provider reimbursement. Probably will take the next half of my life to address all of those. Okay, next slide, please. And third barrier is resources. So again, providers we know are reluctant to screen if they don't have resources to assist those who are impacted by perinatal mental health disorder. And so we need clarity around what resources are available, and there are a lot of resources. There's a new national maternal mental health hotline, there's psychiatry access programs, there's Postpartum Support International with its volunteers and state chapters. There are a lot of resources. We need to better advertise those resources. And we also need to do some research to identify and fill gaps in those resources and identify what additional infrastructure is needed so that individuals are benefited by these resources. Next slide, please. And then finally, the fourth piece is screening tools. So first of all, as we discussed earlier, there are many perinatal mental health disorders, depression, anxiety, bipolar, et cetera. And there is no one screening tool that actually screens for all of them. So to do an adequate screening requires several different screening tools. We also heard that the current screening tools do not adequately address cultural and racial differences. And so ideally, there would be a screening tool that was more up-to-date and culturally relevant, that was better suited to our very diverse and multicultural nation that we currently have. Next slide, please. And then, of course, we heard over and over again about issues of equity and trust, particularly those who are most vulnerable. And so we know that this draft framework is designed based on a characteristic of an average pregnancy with a live birth in the United States. And as Amina pointed out, it's sort of like a one size fits most, right? We could not tell this for all the individual populations. However, we know that this framework must be adaptable to patient-specific situations. So for example, there was a question in the chat about suggestions for screening in the NICU. Well, as luck would have it, I'm actually writing a paper on it. And basically, I suggest that every parent in the NICU should be screened. The rates of PTSD for parents who have a baby in the NICU is about 45%. And so not only should every parent be screened, but resources need to be available. If half your parents are walking out the door with a mental health illness, we need to do something about it. So next slide, please. So we're going to take all of these different barriers and we're trying to now take them to action items. So the first is that we're going to, again, continue to use an equity-focused, data-driven, and evidence-based approach. And then we're going to launch 4 separate task forces to address each one of these specific barriers. So the first task force is going to be focused on education and starting with doing a landscape of analysis of existing educational opportunities. And then identifying ways to formalize education around perinatal mental health disorders, of course, with an emphasis on equity. So this is looking at how do we make sure that this information is being included in medical school, in residency programs, in continuing education requirements, all of those kinds of things. Okay, so that second task force will focus on reimbursement. We know this is a huge piece. Again, starting with a landscape analysis to understand the current reimbursement streams, and then identifying ways that frontline providers can be more easily and more adequately reimbursed for the care that they provide around perinatal mental health. Next slide, please. The next is a task force around resources. Again, starting with a landscape analysis of existing national and state level resources and interventions. So we're not going to get down to like individual providers in the community, but the idea of big picture kinds of things like the National Maternal Mental Health Hotline, the state psychiatry access programs, right? And then identify ways to share these resources more broadly so that we can make sure that frontline providers know about these resources and can make them available to their patients. And then the next task force is around screening tools. And so again, starting with a landscape analysis, understanding the current screening tools and their shortcomings, and then identify opportunities to update or expand them to make them more relevant and more comprehensive. So ideally, we would have a screening tool that could somehow assess for anxiety and depression, that could ask the right questions, that could reach the most number of pregnant and postpartum people in racially sensitive, culturally appropriate ways. And then, of course, wrapped all around this is keeping an eye on equity and diversity as we move forward. So that's our goal for phase 2. Okay, so next steps. Here's where we are right now. So phase 1, we're finishing up our final report, just going through it one more time, making sure we got everything tied up perfectly, and we'll be posting that to MMHLA website, to our website as soon as we can. So hopefully within the next few days. And again, we'll share information with you when the written report is available, but it includes everything that we talked here. And of course, right now we're gearing up for phase 2. Quarter 1 of 2023, we're doing some planning. We're looking for some additional funding. We're looking for folks who may be interested in helping out with any of these task forces. And then we'll be launching those task forces in Q2 of this year, and they'll run for about 6 months. And so we hope that if you're interested in working on any of these things, you'll let us know. We're going to do a survey right after this. We'll give you the opportunity to sign up to get information about any of those task forces in phase 2. We also have listed here our 2 primary points of contact. So Amina Balogun at the Maternal Mental Health Leadership Alliance, and then Nikita Campbell is here from the March of Dimes, and she's our primary point of contact at the March of Dimes for this project. And so again, we thank March of Dimes for being with us on this, and we thank all of you for participating today. And so I know that there are a number of questions in the chat, and we're going to kind of go through those and see. So the first is from Carol Sakala. Thank you, Carol, from the National Partnership for Women and Families. Yes, we'll be posting the phase 2 information. Yep, that will be included in the survey that we give out afterwards, as well as on our website. Okay, so Carol points out that we should also we appreciate that physical and mental health need to be paired together, absolutely, but we also need to be looking at the social needs. Couldn't agree more, absolutely. And it would be really terrific if we could figure out a way to address all of these needs. We absolutely. So Lisa asked about postpartum and well baby screening billed to payers at the same rate. So I think I touched on this a little bit. So again, Medicaid right now will reimburse pediatricians, but of course it's on a state-by-state basis. We have a whole chart somewhere that we can share that shows in some states, providers are reimbursed by $3 for screening, in some cases 30 cents. And so, again, as with Medicaid, it's on a state-by-state basis. And I don't know about private insurance. This is some of the work that we'll be digging into with our task forces during phase 2. And as I mentioned earlier, obstetric care is typically bundled. And so right now, that means, an obstetrician is provided a certain amount per pregnancy, regardless of how many interactions. And right now, screening is not part of that bundled care. So again, something that we'd like to be addressing and making some recommendations after phase 2. Okay, question about what has been the approach to getting pediatricians and OBGYNs, how can we support them? So interestingly, we're just going to step back a little bit, and the American Academy of Pediatrics has actually been very, very strong over the last several years in their recommendations for screening. And they currently, right now, through their Bright Futures work, recommend screening at the 1, 2, 4, and 6 month well baby visits. We've taken that and extended it a little bit further to the 9 and 12 month well baby visits. because of the information that we've learned recently about suicide and overdose being the leading cause of death for new mothers, with the majority of those deaths happening in the late postpartum year. And so, right, how can you help support them? I would say, I would encourage you, every state has its own chapter of the American Academy of Pediatrics, and ACOG, the American College of Obstetricians and Gynecologists, are organized in a district way. So like a district may include several states. I would encourage you to reach out to your state chapters of the American Academy of Pediatrics, as well as your districts for the American College of Obstetricians and Gynecologists, and offer to help them do some training. I think that would be fabulous. I remember when I ran an organization in Virginia, you know, we would just reach out to the local hospitals, to whoever was the point person for maternal infant care, and offer to do trainings. And so you can do this at the local level, at the state level. It just requires kind of putting yourself out there. And we're certainly happy to coach you through some of that if you're interested. Okay, so another question. How does this line up with a framework where OBs typically do not see patients after the 3-week or 12-week postpartum visit? Right, okay, so good question. So let's just back up a little bit on this. So again, the American College of Obstetricians and Gynecologists, ACOG, several years ago put out guidance around the 4th trimester, where they really encouraged their providers to have contact with the postpartum patients within 3 weeks and follow up with a 12-week comprehensive visit. And again, over the course of the project, we heard people say many times that obstetricians typically still just provide that routine 6-week postpartum visit. So there's a little bit of delay in sort of catching up to this new framework. We also know that ACOG is going to be putting out new guidance around screening. And so hopefully they'll be providing their members particular guidance around that. Okay. From Maggie Clark. Hi, Maggie. Do you have recommendations for what to do if the screening comes back positive? How will that positive screening result be shared with other providers? So the pediatrician sharing with the obstetrician, you know, that's sort of at like the individual levels, the hospital levels, the practice levels, for them to figure out. It's a great question and sort of beyond the scope of what we've been working on. So if anybody has any thoughts, we'd love to hear them. Go ahead and put that in the Q&A. What screening tools at this time would you recommend using postnatal? So some of the most common tools are the Edinburgh Postnatal Depression Scale, called the EPDS. And that actually screens for both depression and anxiety and asks about suicidality. And the EPDS has been proven effective in not only the postpartum period, but also during pregnancy. Another screening tool that is used frequently is the PHQ-9. And those are typically the ones that providers start. Okay, my organization is currently very interested in reimbursement issues. Who would be a good person to get in contact with to help support those efforts? That's a great question. Go ahead and email us and we'll help you figure that out. Has there been discussion about screening after a pregnancy or infant loss? Oh, absolutely. Again, that's primarily why we use the wording for the full year following pregnancy, because we want to make sure that covers, we used to say for the full year following childbirth or the full year of the first year of baby's life. But we realized that was leaving out people who had a pregnancy or an infant loss. And absolutely, those parents need all the support that they can get. It's almost like, why even bother screening? They are bereft. I mean, we just need to give them, you know, grief resources and make sure that they are getting all the help that they need. Okay, so about.
Could I add something to that quickly, Adrienne?
Sure.
So sorry. I just wanted to add, we even had conversations throughout the course of the screening project about, you know, people who struggle with infertility, who may not have gotten to the point where, you know, there's even a pregnancy that's lasted very long for them to receive prenatal screening for perinatal mental health disorders. And we know all of these populations are really important to be thinking about when it comes to mental health, and we'd like to bring them under this umbrella as well. But at the same time, balancing that with our current focus for this project was that 2-year time frame. And so that kind of harkens back to what I was saying earlier about, you know, we know that mental health doesn't start or end with a pregnancy, and that we want to make connections to mental health care outside of that 2-year timeframe as well. And I think these are all excellent kind of questions that we can bring up in future phases of this project, thinking about how we can expand this framework or develop, additions to it that will bring in considerations for other special interest populations. So thank you for bringing that up.
Thanks, Amina. Such good questions. Okay, so somebody had a question about what do I mean when I say frontline providers? What I'm talking about mainly are the clinical providers, so obstetric, pediatric providers, so whether that's a midwife, a nurse practitioner, but whoever's providing the obstetric and pediatric care, as well as mental health providers who are providing that frontline counseling. So social workers, therapists, counselors, right? So when I talk about reimbursement for frontline providers, that's who I'm pretty much talking about. Okay, so is there concern for over-screening? We had this question come up a lot. Amina, do you want to address this one?
Sure, I can definitely speak to that. And as Adrian said, it did come up a lot. So there was always someone that would say, is this a little bit too much? Is it overboard? Because I know that my patients would kind of be sick of me, or they would just check yes to all the questions just so they could move on and not have to talk about it anymore. And we definitely acknowledge that as a reality. But at the same time, we wanted to build a framework where mental health conversations would become so much of a norm that perhaps over time people would not be so averse to it because they kind of know what to expect. And they understand it as an important part of their health during their pregnancy and the postpartum period. So there's that element of it, but then we also perhaps we could put a little bit more emphasis on the fact that this framework still leaves space for provider discretion. So we have all of these suggested check-ins for a mental health screening, but at the end of the day, the provider or whoever is interacting with the patient does have some control over how often the screening is happening, one, but also what it looks like. So it might be taxing if you're doing the same Edinburgh postnatal scale at every appointment and people are bored with it. And so instead, you might choose to do more informal check-ins where you say, hey, I just want to check in and make sure your mental health is doing okay. Last time we talked about XYZ. Are you still feeling the same way? That kind of thing, as kind of a way to mitigate the taxing nature of screening. But overall, like we're saying, we really want to make this as robust as possible and have all of these preset check-ins so that both the provider and the patient or the client kind of know what to expect when it comes to conversations around mental health. So Adrian, if you want to add anything to that, please go ahead.
Oh, no, well done, Amina. Thank you. And I was just going through the rest of the questions. We are coming up on time. I just want to see if we can address as many of these as possible. And so some great stuff in there about additional screening tools, in-hospital post-delivery. What tool do you recommend and who would be administering the tool? How would that ideally fit into universal screening education? Oh, great question, Rachel. So a lot of these questions about implementation are sort of beyond kind of what we had in the scope of this project, but are all excellent questions. And again, like each system has to figure this out on their own. I hate to say it, but hopefully electronic medical records will be, a step that helps share some of this information. So for example, in the last question that I just read, if somebody is screened in the hospital, how do we make sure that information gets back to their obstetrician, or who's going to take action on it, right? So there's all of these minor things. I shouldn't say minor. There are all these very important things that need to be worked out. And again, that was sort of beyond the scope of this. As I said at the beginning, these were all questions that we could have addressed. And we really focused on, if we can get to the when and get agreement around the when, then we can start working through some of these other problems. In basic implementation problems, right? And the devil is always in the details. So these are huge issues that every organization is going to work through differently. Okay, so there's something about resources, and I just want to take a second here and talk about a really fabulous resource that is available to everybody, and it's the National Maternal Mental Health Hotline. And this is a federally funded program that provides a 24/7 voice and text hotline, and we'll put the information in the Q&A. It is funded through the Department of Health and Human Services with a contract to an awesome nonprofit called Postpartum Support International, PSI. Probably many of you are familiar with PSI. And the hotline, again, is answered 24/7, voice and text, by both English and Spanish-speaking counselors, therapists, peer specialists, and they have access to translation services for about 60 other languages. And this is a free service. Any mother, any father, any parent, grandparent, anybody in the family can call, can get information, some brief intervention, and some resources. PSI has some great resources. They have volunteers in every state. They have support groups that they offer, and they have a great directory of mental health providers all around the country who specialize in treating these illnesses. And so I would highly recommend that resource to any and all of you. And these are the kinds of additional sort of high-level resources that we will continue to advocate. So we are just about out of time. Amina, maybe you could stop screen sharing and we could just turn it over again to, I'm going to put Tiffany on the spot if you have any words of closing for our terrific audience. And then I'll just follow up with, some last minute housekeeping.
Sure, thank you. I will say this was a great conversation. Appreciated all of the questions, and all of these are so relevant right now. We know that there are significant barriers and that this is the beginning, right? There's a lot of work to do. We're excited for the amount of energy that we've seen today and invite you to participate, join us in this effort as we figure out how to overcome these barriers and bring this into the next phase of work. And I'll also say, there are tremendous efforts going on beyond just our two organizations. So please do be in touch to tell us what you're doing. I often tell people that innovation should be more about collaboration than anything else, right? It's lifting up the ideas and the efforts that are already successful and expanding them to reach and impact the most people that we can. So please let us know if there are efforts that you're doing that we should be involved in, that we should be collaborating versus starting from scratch. We would love to hear from you. And thanks again for joining us today. We appreciate your time.
Thank you, Tiffany. And so there's been many questions about how to get involved. We have included the information, the emails in the chat for Amina and Nikidra. And we are going to launch a very short survey just to get a little bit of feedback from you. And you'll be able to click whether you'd like us to follow up with information about these. So again, many, many thanks to all of you. It's been a terrific audience. We've had some really great questions and conversations. Thank you to the March of Dimes for being with us here today. We're wonderful staff at MMHLA. And again, we'll look forward to following up with all of you with information about our website. So stay tuned. We're going to launch a survey and we'll follow up with an email. So thank you all. Have a great afternoon.
Great. And I actually have to close the webinar out before the survey launches. So this will be our final goodbye. And as always, my inbox is open if you have any questions. So have a great day, everyone.
Thank you.